I will be speaking this afternoon on the broad area of medical ethics. One of the really fun things about organizing these programs is that I get to talk about a number of pet likes. One of them for me is medical ethics. Now, ethical practice is something that pervades every dimension of practice, or at least it should. And it forces us to think about why we do the things that we do, or how we should do things in certain situations. And we make constant reference each time to what we do in this environment and what we can't do in this environment, or what obtains in another environment. But the truth, of course, is that the reason we say those things is because we have a certain context here. But the underpinning principle still is that we have a duty of care to patients. We have a duty to preserve autonomy for the patient, for ourselves as well. So it's a cardiovascular conference and psychiatry conference, but ethics is still something that's really relevant. So we'll be talking for the next few minutes about ethical dilemmas in the management of cardiovascular disease. I would encourage you to, as we do this, to reflect on this and to extrapolate as far as you want, really, beyond the realms of cardiovascular disease. Because as we said, medical ethics is something that pervades every aspect of practice. Okay, so we'll make it quick, and I'm hoping that we will interact quite a lot as we go through. Right, so being a general practitioner, I will start with what we call the 4 principles. The 4 principles that are important anytime we make contact with a patient, anytime we deal with our colleagues, anytime we do anything that remotely has anything to do with patients. Now, there are 4 things we must absolutely make sure that we've nailed down. And these things really should disappear into the very framework, fiber of our everyday practice. So we don't really spend a lot of time thinking about them. Now, these things are: do good, whatever you do no harm, be mindful of the principle of justice, and I'll come back to that in a bit, and then autonomy. Justice, yes, it does go beyond just doing the right thing. It also has to do with how we appropriately apportion resources so the right person gets the right thing at the right time. Again, that can be difficult in an environment in which resources are limited, which in reality is every environment. It's a question of degrees. And then autonomy. We must wonder, whose autonomy are we talking about really? My autonomy as a doctor to practice as I know best and as I see fit, or the autonomy of the patient to determine what is best for their own lives? There's a balance to be struck between beneficence and non-maleficence, between the desire to do good and to do no harm. Doing no harm, by the way, goes beyond the individual patient. It's also doing no harm for society as we look at that one patient that's directly in front of us. As I said before, let's remember always that all this is grounded in the context of the consultation. All these things come into play every time we speak to that one patient. And we make decisions that have to do with the life of that one patient. Now, there's also autonomy versus autonomy, as I touched on earlier. Whose autonomy? There may be times when my autonomy as a clinician clashes with your autonomy as a patient. We need to be mindful of these things and find the balance in there. And autonomy versus paternalism. We are in an environment in which the way we know to practice is to be as paternalistic as we can be. Patients expect it of us, in fact. They come to you because you know best. But the danger is we assume more and more that we know best. We begin to believe the legend about ourselves that we know best. And that, at a certain point, begins to erode our own professional integrity. So all of these things come into play, and it will vary from context to context where the balance is struck. But the absolute underpinning principle is, if you do nothing else, do no harm. If you do nothing else, do no harm. So, and all of it is underpinned by the principle of best interests. Okay, so where the patient's best interest is somewhere. That balance is struck somewhere in the middle of all this. And as I said over and over again, it comes into play when you see that individual patient in consultation. There are a number of things that further complicate this already slightly complicated situation. It's interesting. It's not complicated until we begin to think about it. I mean, you and I don't sit in consultation thinking, oh, I must preserve my autonomy, I mustn't be paternalistic. But the more we reflect on these things, the more complicated it gets. Well, there are a number of things that will complicate it even further, and that's the fact that we are human. And we all have a particular view of the world. We all have a particular view of the world, particularly in the context in which we practice. So think about those 4 principles again. There are a number of ways in which we can look at those 4 principles. There's the deontological view, which says, really, there is a right way and a wrong way. And this is what I've known all my life to be correct, and this is wrong. So therefore, this will be correct for every single patient, and I know best, and this will be wrong in every single situation. There's a sort of slightly utilitarian view, which I must say an environment like this encourages or it forces out of you, and that is the view that says, well, as long as the end result is right, how I get there doesn't really matter. But then we can begin to see how that affects our day-to-day walk with the patient. So there's that view that says, as long as I get the desired result, what's between here and there, is totally consequentialist. And then, there's a virtue theory that says, well, this is the way my trainer practiced. I've learned this by example, so it must be the right way, and so on. So these things further complicate what is already complicated. And as general practitioners, how many general practitioners in the room? A few. And not just general practitioners. We exist within an ethical minefield, don't we? We have a few minutes to absorb all the risk that the health system brings. Think about it. You sit with a patient for 10 minutes, you take a history, and you make life-transforming decisions. Think about how much risk you've absorbed within 10 minutes. So it's really important that we come to grips with these things. And really, our only safeguard is this in that situation. The relationship, the ongoing narrative, the rapport that you develop with the patient over time. And as general practitioners, for some of us, it's generations. In my practice, I'm starting to see the 2nd generation of parents. And I'm beginning to of patients. I'm beginning to recognize certain trends and patterns from their fathers, and in some cases, I'm beginning to see even grandchildren. So we cannot know or do everything in 10 minutes. But if we are committed to a lifetime of interaction with the patient, there's an ongoing narrative that unfolds with time, and that's the way that risk gets absorbed over a period of time. But again, we must be careful to be aware of the ethical principles that guide and frame our practice. What is good clinical governance? It's simply doing the right thing for the right patient at the right time in the right place. So it's making sure that every patient, everyone you see in the course of your practice gets the right thing out of you in the right context. They get what they need at the point of need, and that they are not shortchanged in any way. Well, rewind very quickly to the 4 principles. If we're going to achieve this, we need to be sure that we're observing do good, do no harm, justice, autonomy. Now we begin to think about it, it's looking a little complicated, or perhaps not. But we don't think about these things, do we? So there's a relationship between good clinical governance, which we all aspire to, and the awareness and practice of ethical medicine. We cannot be who we are without an awareness of good ethical practice. So I'll expand that my very simplistic definition of good clinical governance a little bit. It's a framework that ensures that we act in a timely manner, that we have the appropriate training, we accept our limitations, so we are able, therefore, to act in the patient's best interests. Don't forget, it's all about best interests. So whose best interests are we talking about? First and foremost, the patient. But there's also your best interest as a clinician. You're there to serve the patient, however. Now, all of this does not mean that we do away with our own autonomy. Because there is a certain responsibility that time and experience and knowledge gives to you. And you're in that position, you occupy that position so that you can do something on behalf of the patient. So we have our own autonomy, and that autonomy may sometimes clash with the autonomy of the patient. Again, finding that balance, where that balance is, depending on context, is where the patient's best interest will lie. Again, we've talked about clinical governance. I've just said this, accepting our limitations. We need to be committed to working together with colleagues and with patients, believe it or not. Now, going back to what we know, that very heavily paternalistic way of doing things, in the old days, we didn't really take the patient's ideas, concerns, expectations into consideration, did we? But more and more, we are being forced to do that, because before your patients come to you these days, I see it in my practice, they've Googled it. They know what to expect. So they really don't come to you for knowledge anymore. They come to you for skill and wisdom, okay, which is knowledge in practice, okay? The application of knowledge is what they come to you for. They are already expert in their own condition. And you hope that they are before they come to you. Now, that is the future of practice. And I'm sure that is what we're beginning to see in all of our practices here. So we need to be able to accept our limitations, okay, to our colleagues, to our patients as well. It's all right to say, it's good clinical governance to say to your patient, actually, I don't know. Let's look it up together. So the message is, we need to do away with paternalism. But that's a very broad statement, isn't it? Is there an argument that says that a certain amount of paternalism works in certain environments? Maybe. Maybe not. My point is that it will vary from environment to environment, but none of that should do away with the fundamental right of the patient to their own autonomy, or to have the right thing at the right time, in the right place, in the right way done to them. Again, what we aspire towards is safeguarding high standards of care, creating an environment in which clinical excellence will flourish. We have a number of tools. We must be committed to auditing our own practice, reviewing complaints, significant events analysis. We must be open, is what this is all about. We must be open. And increasingly, the new frontiers of medicine demand that we are open. We are moving away from a time and a place where we were the font of all knowledge and we could keep everything to ourselves. It's a partnership now with our patients. We must be prepared to share management plans. And there's certain consultation models that support that. And I'm really hoping that in one of these masterclasses one day we'll be able to do a series on the art of the consultation. So what does all this have to do with cardiovascular disease? Anyway, Dr. Johnson's going to ask me that in a minute. Yeah, these GPs, they just waffle along about things that have no boundaries, like ethics and consultation skills. What do all these things mean? Well, we deal with real patients. They see you once in 6 months. We're in touch with them every day. So we need to get in under their skin. We come to know the family, the social, cultural, psychological context in which they are grounded. We come to recognize patterns of disease. So general practice is about pattern recognition and building rapport and that narrative, and so they can go and see Dr. Johnson once in 6 months and he can offload them once they've had their angio, but then you get the headache when they've been discharged. And you need to be aware of these things. So what does it all have to do with cardiovascular disease? Okay, it comes back to the principle of justice. Remember we talked about this briefly at the start. Justice in the ethical context is about making sure that people get exactly what they need in an environment in which there are limited resources. And that is life, isn't it? You and I are the gatekeepers of that system. So how do we determine that people get exactly what they need? How do we determine that? The principle of ethical and equitable distribution of resources. We have that huge responsibility. So in other words, how do we determine who has access to an angiogram, angioplasty, primary and secondary prevention? Who gets statins when they need it? Who gets those new fangled drugs that we'll talk about, that Dr. Johnson will talk to us about later on? Who gets to see Dr. Adeyemi Johnson? Florian, sir. Dr. Johnson's an old boy of my school. I can say anything and get away with it. A senior old boy of my school. Okay. So who gets access to screening and treatment of mental health systems and cardiovascular disease? Who is selected to be privileged to have access to all of this? And who are all the poor sods who won't get it? And why shouldn't they get it? And who's responsible for making sure that they get it or they don't get it? Really difficult ethical questions. And it goes beyond you and I. It also goes into the fiber of that framework I talked about earlier on. And we'll touch on that a little bit more later. It begs the question, therefore, how do you make decisions? How do you and I make decisions? What sort of decision models do we follow to ensure that the right person gets the right thing at the right time in the right place? To ensure that in this context, in that atmosphere of very limited resources, the right people get what they need. To ensure that it's not just a postcode lottery. We don't have postcodes here, but to ensure that it's not just people who have all the money in their pockets that get the right treatment. Well, it's a function of your knowledge, expertise, how you deploy that, awareness of our knowledge gaps, acceptance of our limitations, what resources we have, and this wonderful phrase here, good medical practice, which is guided by what? Ethics. Back again to medical ethics. We're talking about this quite a lot, really, because that is the heart and soul of medical practice. Without it, we are soulless and have no real reason to exist as doctors or nurses or physiotherapists. Without an awareness and a good grounding in the concept of do good, do no harm, justice, and autonomy. In other words, again, back to good governance, and we've seen the link between good governance and good ethics. This really is meant to get us to reflect. It's not a teaching session. It's really meant to get us to think about why we do the things that we do. So, to pull it all together, back to that question that Dr. Johnson would love to ask me, what has all this got to do with cardiovascular medicine? We're going to touch on a number of case studies. He's gone. Where's Dr. Johnson? Please get him back in here. So, case studies. The first one, 40-year-old gentleman. He's 40. Banking executive. He's a real young and upwardly mobile chap. Okay? He's fit, he's well, he's active, he's got a BMI of 24, he looks after himself. He has no pre-existing disease, he has no problems, he's not diabetic, he's not hypertensive. Good cholesterol, total cholesterol HDL ratio. Family history of diabetes. His father was diabetic, had a stroke at 58. Now his friend, which is perhaps the motivating factor, his friend had a heart attack at 24, 2 weeks ago. Now, I hasten to add at this point that the incidence of coronary heart disease, cardiovascular disease, I'm sure you found in all your practices, is dropping, isn't it? We have 35-year-olds who are dropping dead now, okay? A lot of it is type 2 diabetes, we just don't know it. Now, his friend had a heart attack 2 weeks ago. Now, this chap comes along and says, may I have 80 milligrams of atorvastatin, please? I want it now. should he get it? Yes. Did someone say yes? Yes, sir. Oh, why would you say yes, sir?
Because he has a family history of stroke.
Okay.
He's 40 years of age. He's a banking executive that is exposed to so many things in terms of poor diet, poor exercise, and so many other things against him. And he's in a very bad environment too.
Okay. Oh, there you go, sir. That's one view. Yes, one point of view.
According to one of the lectures we had last year,
Yes.
I think the lecturer was telling us that it should be of more benefit if one can go on daily dose of azoxystrobin and on daily basis. And aspirin.
An aspirin, yes.
Yes.
Yes. For which group of people, though?
For 40 and above.
40 and above.
Yes.
Yeah. Certainly the evidence does suggest that diabetics above the age of 40 should be on the statin. Okay. But this chap is asking ethical dilemma. This chap is asking for 80 milligrams of atorvastatin. He's 40. No real personal history. A friend had a heart attack, so he's scared. So we've had one point of view that says father has, yes, there's a family history. Good. Yeah. Very strong. That's right. So for him, his risk would probably, and I worked it out just before I came out, his risk is probably about between 8 and 10% over 10 years. So we've had one point of view that says he should have 80 milligrams of atorvastatin.
Sorry, I want to complicate the case a little bit. Assuming this 40-year-old is also a chronic smoker and has some long-standing history of smoking, would that have changed the view of, may I have 80 milligrams of atorvastatin?
Yes, Dr. Lawney, but he's not a smoker. And that's part of the point. That's why there's an ethical dilemma. Okay, any other points of view before we ask for an expert point of view from a medical?
I'm a little worried about the ratio, the low cholesterol HDL ratio of 3. That's significant. And but I would definitely not give him 80 milligrams of atorvastatin. Rather, I would want to give him low dose of aspirin and keep watching him.
Go on. So, as many points of view as possible, welcome. It's ethics. There's no right or wrong. But context is important.
He'll probably just go and buy it anyway from MedPlus if you don't give it to him. So you want to really find out why he wants the atorvastatin and try and get to a balance, or probably giving him 10 if he wants something. But if you don't address it, he'll probably go and buy it outside.
Okay. That further complicates it. It takes it, so that's an ethical dilemma of a different dimension. Fantastic. He will buy it if you don't give it to him. Great. Thank you very much.
Because he would have been able to find out why he wants it in the course of discussing with him.
Okay.
So now you know why he wants it. Your counseling probably will prevent him from going to buy.
Would anyone ask the patient why he wants 80 milligrams of atorvastatin? Does it matter?
We should ask. Because most of these are patients, seriously speaking, like you rightly said, they know everything about the medical field. All they require from you is a skill. They will download everything about a disease from the internet. And you find out that this guy is up than what you think he is. So it's only your skill
Yes.
and your experience that will actually come in.
Great. Yes. So ethical dilemma of a further dimension. The doctor as a slot machine. Come to me, push my button, you'll get whatever you want. Yes. Correct?
You are correct.
So I'm a slot machine. Okay, because you've researched it on the internet, you come to me, push my button, 80 milligrams of atorvastatin comes out. Right, okay. But there's also a responsibility on my part to have a bit of knowledge as well, isn't there?
Because he wants to ensure that what he read from the internet is correct. He will believe in you that probably you know better.
Okay.
And some of them who go to the internet actually want to educate themselves so as to be properly informed when you talk to them.
Okay.
So it might not just be that you're a pump machine.
Yes.
It's something to be sure
Yes.
from a doctor he has confidence in.
Fantastic. So, what we've done in the last 10 minutes, tease out some of those ethical issues that are really important. We want to do the best that we can. We don't want to do harm, okay? We need to be conscious about how paternalistic we are in that consultation. We want to be aware of the patient's ideas, concerns, expectations. And we just want to do what we can in the best interest of the patient. But at the same time, we have the responsibility that knowledge brings, okay, and we need to be prepared to share management plans. I will ask Dr. Adeyemi Johnson now to offer his view.
You want my ethical view or my medical view? Or both? Okay. Well, if I came across this guy, I would ask him, okay, why? Why do you want 80 of atorvastatin? So that will help us decide how we're going to move forward. But I agree with him that he needs a statin drug. I agree. Now, he's not at any particular risk. He's not. Oh, sorry, is he diabetic? Sorry. Oh, I thought he was diabetic. Sorry. Oh, sorry. Oh, okay, let me retract my something. He's not diabetic, not hypertensive, low cholesterol, and low. So all his indices are very good. Oh. Okay, I would order one more test. Blood test. Apart from asking him why, I will ask for a high sensitivity CRP. Okay, it's one of the new markers of that indicate risk for coronary artery disease. CRP. It's a C-reactive protein. All right, but when you order the test, make sure you take high sensitivity, because the high sensitivity will measure the risk for coronary artery disease or cardiac event. If it's high, you're at higher risk regardless of all your other values. And two, if you order just CRP, that will help you. It's like a ESR. It will help you gauge how well the person is responding to your antibiotics and stuff. But that starts from 2 and above. So you don't want that. You want a high sensitivity that measures on that 2. So anything above 2 is high. So if it has high sensitivity CRP is high, then, okay, 2 things. Yes, if that is high, using evidence-based medicine, then he should go on a cholesterol drug. Not necessarily 80 milligrams of atorvastatin, but the only study that has studied people like this and used medications is been the Jupiter study. And they gave people who did not have high cholesterol, who had low risk, normal cholesterol, and had high CRP, rosuvastatin. And the mortality and cardiac events were reduced significantly. So if he had that. Now, if he didn't have it, there really is no evidence to put him on a cholesterol drug. Everything is good. But if I was him, since my dad had a stroke at 40-something, I would just generally take one low-dose Lipitor or something. No. Maybe Alpha. Anyway. No, it won't. Well, okay. No, how do you differentiate the system from the environment? So, but it is a difficult question to answer. But if his high sensitive CRP was high, easy. I put him on a drug.
Okay.
Yemi, you answered that question from your knowledge and expertise. When we were answering, none of us mentioned CRP. So let us assume we don't know about it, or we are practicing it somewhere. We want you to answer the question.
And Dr. Ukpong took the words right out of my mouth. Dr. Johnson has the luxury of sitting in his practice, and he will order these fantastic tests. You and I have to absorb this risk in 10 minutes flat. Make that decision in 10 minutes flat without the benefit of a highly sensitive inflammatory marker. Sorry, Dr. Johnson wants to respond to that.
Excuse me. You see, there are so many limitations with us in this environment. Most of these investigations are not within our reach. If not Mikio and SB that is available now, most of these investigations are not available. So most of our judgments are based on clinical experience. So sometimes your decisions are usually biased. This is a patient that is coming, is highly knowledgeable. He has gone on internet, he has a family history. Now a friend of his has died 2 weeks ago. He is already apprehensive. And we are in a terrible environment where we cannot go further. Yes, if you are closer to the teaching hospital, you have access to all these investigations to back it up. But now you are caught in a corner. This patient wants to ask you, look, my father died of this. I don't want to have this problem. My friend died 2 weeks ago. I don't want to have this problem. He is a bank executive. He has read a lot. Now he wants your advice, yes or no. This is the question. Forget about CR because you don't even have access to it. So you can see that we are now at a crossroad with this problem.
Oh, I thought this was your section. Well, I know what I would do. Very easy. I said if it was me, I would take Lipitor. No if and of but. I don't have any scientific data to back it up. All right? But there's many things we do that science has not yet studied or has not yet proven. So I will now weigh the harm versus risk. I will tell this man, maybe I'll check his cholesterol profile carefully, see what his LDL is and all that. Not just the ratio. Because his ratio might be low because of his HDL being very high. So I'd like to see what his total LDL is. If we have the ratio, we will have the LDL. So I'd like to see what that is. But
His LDL is
2. What's that in milligrams?
I'm not American.
I use milligrams, eh?
Okay, total is, in my
2?
language, his total
What's 2 times
is 5, and his LDL is
Okay, that's 2 times 38 is what? It's low. 2 times, what's the total? 5?
total is 4.
Total is 4. So 38 times 4. So HDL is very high. This man has all the good indices. And, well, I would recommend, if he has to take, he's made up his mind he's going to take this. Now, but there are 2 things you people are saying that is a bit of ujuru there. He's a bank executive. You can send him to Patcare and they can get into the high sensitive CRP. That's 1. 2. Yeah. But there's one thing I would tell him. That your HDL is very high, which is good. Very protective. Your LDL is very low. Very protective. Maybe we can find out whether his dad was a smoker or something like that. We don't know. All right. The next thing is, I will let him know that 80 milligrams of atorvastatin can actually reduce his HDL. All right, which will not be in his favor. 10 milligrams can actually lower the LDL and increase the HDL a little bit. All right, but 80 milligrams, as you'll see in one of the slides later, brings down your HDL as well. So I'm not sure what good that would do. But 10 might give us between placebo and some effect. But I think it would be important to find out what his dad's risk factors were as well. That might help give us some guidance. But as a bank executive, he can go to Patcare and cleaner labs and get his blood work.
Okay, fantastic. So I think what we've managed to establish here is that the evidence-based approach to this, and this case study was deliberately written to tease that out. The evidence-based approach to this is that he gets nothing. Really. He has no risk factors. Lots of good cholesterol. Very little bad cholesterol. He has no real personal history. If he was diabetic, yes, I'm not sure I'd give him 80. I wouldn't give him 80. I'd give him 40 milligrams of simvastatin or 10 milligrams of atorvastatin if he was diabetic, but he's not. So he has no risk factors whatsoever. He's coming to me because he's scared. His friend died. he can afford to take it, and he thinks that perhaps, because he's a bank executive, the power distance is so great that I would be pressurized to sort of let him have it. But the point is, would I see the next person the same way? Would I deal with the next person in the same way? And also, the fact still remains that he can go to MedPlus and buy it, okay? And that takes away the justice issue. The next question is, what would we then do if we had a sort of governance framework that did not allow him go to MedPlus to buy it? Which is what should obtain. It's a prescription drug after all. So I would then have to reassume my role as gatekeeper and determine, in conjunction with the patient, who gets what. And that goes back to the clinical governance argument. So assuming I were constrained by the framework of what should be a right and proper practice environment, what would I then do? The evidence suggests that he shouldn't get atorvastatin, let alone 80. So it goes back to the ethical principles. And I would say the balance in there, my autonomy versus the patient's autonomy. He has a right to request it. I have a right to politely decline. But I have a duty of care to him or her still to explain the reasons why it is expedient to decline. Okay? Share all the evidence that Dr. Johnson has shared with us today and say to him, you're right to be worried, but these are your risk factors. They're not hugely impressive. You're at minimal risk personally of developing this. You're not related to your friend. But you are 40, you're in a very highly pressured environment. You and I need to be committed to monitoring your risk factors over time. And for me, that's where the balance would be. Absolutely. That's where the patient's best interests would lie. And it would then be down to my communication skills and my awareness that it's a partnership with the patient to win them over. Because that is, again, the great power that you have, the power of influence as a doctor. Because, yes, as a bank executive and all that, he comes in, but he trusts you. Okay? So that really is, yes, ethical practice, the art of the consultation, communication skills, everything wrapped up into one. And you walk away with your professional integrity. Is that a good balance? We'll do this very quickly. We've got a hang of it now. So, 60-year-old lady. She's diabetic, okay. She's hypertensive. She's on medication. She's depressed. All right? Sorry. Previous history of suicidal attempt. Her son died in a car accident a year ago. She's going abroad for 6 months. And I experienced this, actually, a similar case. Where she's going, there's no access to medical facilities. And it doesn't necessarily mean that, she's going to a jungle somewhere. Maybe she's not part of that health system, so she can't access, And she says, may I have a 6-month supply of all my medication, please, before I go? Please, doctor, help me. Legitimate request, legitimate, it's all her medication that's been prescribed. And just so that we cut through this quickly, we are operating in a framework that doesn't allow her to go to MedPlus to get 2 suitcases worth of medication. So you are the gatekeeper. What would you say and how would you handle this? Dr. Johnson still thinks all this is fluff.
It's a very difficult thing to say. Since there is no monitoring system for the level of the diabetes and hypertension, give him continuous drugs might cause a disaster.
The patient is on regular medication.
I know.
She already has regular.
But without any monitoring system, whether it is going up or it's coming down.
Okay.
Well, the level at which the diabetes is, whether it's being controlled or not.
Let's assume
let's
assume she's stable. You've known her for many years. You've been seeing her every 3 to 6 months.
And that thing has been fixed.
It's fixed. She's stable. She's got an HbA1c of 6.5. Diabetes under control. Blood pressure 120/70. She's stable on amlodipine, ramipril, the works. So then you're not going to change anything.
In as much as I say yes with reservation.
Yeah. Okay. Would you give her any at all? Not really. Okay. Sorry, his hand up. Yeah.
I think this patient would, you want to give something to the patient, at least to sustain her for some times, maybe 2 or 3 weeks. And then you will tell her that there's no country anywhere in the world now where you don't have a medical facility.
Sorry,
And
just
then-
one at a time. Sorry.
Yes,
Sorry.
that there's really none. And the embassy in the country can really assist to get a doctor with the embassy, our own embassy. Not at, no, hold on, not. The patient is not a Nigerian. Is he a Nigerian? Hold on, is the patient a Nigerian?
Yeah, she's Nigerian. Yes.
Is the patient is a Nigerian?
She's Nigerian. Yes.
Oh,
She's Nigerian.
Okay. Okay.
But she's going somewhere where she will not have access
Okay.
to.
Okay. Oh, I thought you were giving us a scenario from Britain or something.
No.
these are
No,
all
these patients are
Nigerian
grounded
cases.
here. They're grounded here.
Oh, is another thing in it.
Yeah.
I have to think about that.
Yeah. Oh, sorry. Just one minute, Dr.
I think we should guide against certain things in our practice, allowing patients to dictate to us. I think it's a very common thing in our practice now, and that we must guide against, and that has to go along with our ethics, justice, and virtue. I would decline this, please.
Great. It's great to decline, though, but what would you then do for the patient? You'd leave them with no medication, or how would you mitigate any potential?
I have my medical integrity to protect
Come
in this case.
Okay.
I would rather advise her to go to the embassy, wherever she is, and she should get the appropriate thing done.
Okay, great. So Dr. Upong and then Dr. Sule, and then we'll come back to you.
I think it's pretty difficult, a tough situation here, but I would certainly not give her 6 months supply of medication.
Sorry, can we, Dr. Upong has the microphone. Just one moment. Please.
I would not give her 6 months supply.
Okay.
Or give her the prescription as indicated I normally would give for the short periods of monitoring. But I'm concerned also about her suicidal tendencies.
Yeah.
And perhaps might want to look into that. Psychiatrists will know better whether I would like to give her the medication, antidepressants, to go. But certainly, I don't think, even though she hasn't got access by virtue of lack of insurance and other things in the place she's going, if she's in real difficulty, she will have treatment.
Right.
So I think that we should advise her that accordingly. But embassy, I don't think that you have traveled in the last 2 years or 3 and contacted Nigerian embassy. Please don't go there. Don't go there. The patient will die in the embassy hall.
Okay. Thank you.
Let me just say this quickly.
Yes, sir.
I think this is straightforward. If this guy or this lady has money to go away for 6 months, she should also have money at least to go with the prescription Dr. Okwan will give to another physician there who can write that prescription if it's necessary for a fee and can also review him. My advice is you may go on 6 months, but also have a little extra cash, so that you need consultation to be able to pay for it.
Yes.
Because how can you go for 6 months with all these?
Yes.
Excuse me. Please, there is an aspect to this thing that I want all of us to look at.
Sorry, no, the interaction is great,
You
but
see,
still one at a time.
There is
please.
an aspect to this thing. Excuse
There are no facilities. Yeah, no facilities.
Excuse me. Excuse. You see,
She's going on a mission to Uganda in the jungle somewhere.
I want to bring in one little story. There was a pipeline busting by these illegal bunkers at Abule Egba there. Abule Egba. Many people were burnt in the fire outbreak. But one of the NNPC officers said, look, some people were saying it's because they are poor, they wanted money to do that. They said, look, poverty is not a reason to steal. It's not even an excuse. You understand? The fact that this woman needs this thing does not mean we should do it in an illicit way. Okay, everything we have to follow medical ethics and we have to follow a standard practice. You see, we should not encourage, he's going into that country as a illegal person. He's going to meet an illegality there. Do we still continue to encourage that? On that basis, I would say no.
Sorry, I won't use the mic. Can you guys hear me? Yes. Okay. I mean, I was really happy about the person that considered the psychiatric history. Now, the psychiatric history, I think, is important for a number of reasons. One, you would need to do a risk assessment. This lady is depressed. She's had a suicide attempt. I would be interested in knowing how severely depressed she is. I'd be interested in knowing.
Sorry, you could ask us to use the mic.
Okay. I would be interested in knowing if she has any current proactive suicidal tendencies and if there's a high risk. Now that will inform you because, I mean, she could be going there to commit suicide. Yeah, and you've also got to think about her care for a psychiatric condition when she goes there. So I like talks, for these things, sometimes there's not a right or wrong answer, but it's thinking through these issues. And remember, she's not just a woman with who is suffering from diabetes and high blood pressure, but there's also the psychiatric history which you've got to take into consideration.
Additional. Just as a rider to what you've said, I will, looking at the scenario, the health situation of this patient, I will try as much as possible to dissuade her from making an urgent traveling now. You need to take care of yourself locally where you are sure to get medical care, and it's in your best interest to do so and put off this journey to some other time.
Okay, just one more, and you're absolutely right, Dr. Shona. Just one more, and then we have to move on.
Hello?
You
Hello?
have the answer.
Hello?
Just one more, and then we'll take Dr. Yemi Johnson. Just one more. So
I want to make this comment. This is a kind of patient we cannot afford to live alone without taking our medication. The diagnosis has been made already. I think what this patient needs is a counseling session with the care provider. A counseling session finding out why must he travel, why for 6 months, what's the reason behind that? Is he going alone? Any care supporter, any care giver going with her that you can handle this patient to, that can supervise the administration of her drugs. She's been stabled on all these drugs all along. She's been taking all these drugs and she's stable. She wants all these drugs, she wants to go with all these drugs. Somebody must be with her to supervise, to make sure she's doing the right thing, what she's been doing all along. I think this counseling session is important.
Great, and that goes back to what Dr. Sule said about
because you mentioned that there are no, she has no access to medical facilities.
Yes, we have said that. That's true.
No access.
There's no access.
So the best bet is to get somebody. Okay. Yes.
But I think the key thing there is, it goes back to what Dr. Sule said earlier. A risk assessment is really important because she may be going to commit suicide. Okay, thank you very much. I'll just round up by saying all of these considerations are very important. And we've been able to think through the scenario. As Dr. Shona said earlier, the answers are here. We need to ensure that we are acting in the patient's best interests. She needs the medication, true, but she also needs not to commit suicide. Okay, and we need to know where she is in that spectrum, as Dr. Sule has said, risk assessment and all of that. Again, our communication skills are very important. We may need to persuade. But I'll just close by saying what this actually is based on a dilemma I had about 5 years ago. Very depressed lady, suicidal, had been suicidal in the past, on lots of chronic disease medication. She wanted to, from Bedford, where she lives, she wanted to go up north to Yorkshire to see family. And she was going to go for such a long time. And she asked me if I wrote a case study on it, can I have a repeat prescription, please? Now, prior to that, this lady had been such high risk, we'd been giving her 7 days supplies of medication. We had been giving her medication every 7 days. Her repeat prescription was 7 tablets, full stop, of everything. Okay, now all of a sudden, can I have a prescription for 3 months? And I had to think really carefully about this. I had to think about all the things that you've discussed here today. But then again, I had the advantage of operating in an environment in which there is a framework. There's good governance. She will not get that prescription from anywhere else if she doesn't get it from me. Okay? So eventually, what I decided was this. I agreed with her that, listen, I can't deny you your medication. It would not be in your best interest to do so. Okay, and I could do more harm than good. But at the same time, I can't give you an umpteen supply of tablets because you may sit here now and say you're not going to commit suicide, but I really need to work with you. So what we agreed was I gave her her usual supply, and I made contact with her pharmacist where she's going, who took on the responsibility for the next 3 months of dispensing the medication periodically.
Because she has access.
Because.
What you said that I was going to
Yes.
And I was wondering whether it's to Moon or Mars.
No.
No matter where she went, that was some access.
My experience is different from the case study, though, in that, yes, there is no access.
If I can say, you've said it
Yes.
here. Between your doing no good, doing no harm, autonomy.
Yes,
Is that
very important.
Well, if the patient wants to commit suicide, you've done your best.
Yes.
You've shown the things well, she's welcome to. There's autonomy.
It's not that straight.
It's not that straightforward.
But what are you going to do? Restrain her?
No.
You've given her all the advice. And if she wants to come
Provided you documented everything.
and you documented everything else,
Otherwise, still be in trouble with the regulation.
don't be like Jesus Christ.
I have a comment. This is easy. There's no ethical
So,
dilemma
if I
here.
just finish that. Okay, go on, sir.
There is no ethical dilemma here. You people are making this thing complicated.
I said it. Yeah.
You see? Maintain your lane. Treat what you know how to treat. When she comes with this suggestion about 6 months and you're thinking about suicide, it's not no. Send her to a specialist. Send her to psych. Let the psychiatrist evaluate and decide and let you know what he thinks. Yeah, but for us non-psychiatric people to start making diagnoses and suicidal ideation and ideas and all these things, I think we're taking things too far. There are people who are specialized in this thing. I know in the US, if this case happened, it's not going to be a problem. Cardiologists will send back to the primary care doctor. Say, Dr. Shitabe, take your patient home. And then he will send to psych. Because anybody who gives that lady a prescription without psych's involvement is looking to lose his license.
Yeah. Yes, of course.
Dr. Johnson, I take your point on board, but again, looking at the social-cultural factors, in Nigeria, there's a lot of stigma with psychiatry, and hopefully we'll address it in my next talk. Because the thing is, as GPs, I believe there's going to be an increasing responsibility on them to make a diagnosis of depression and anxiety and treat. Because if you're going to send that woman to a place like Yaba Neuropsychiatry, the home of wearies, let's be honest, there's still that stigma. There's still that stigma there. So again, that is something you've got to take into consideration.
In closing, and I thank you all for your active participation, the difference between my personal experience with this lady 5 years ago and my case study here is this. I've said all of this to say this. The issue of ethics has a lot to do with you and I, but it also goes beyond us into what sort of framework in which we exist. Okay? The context in which I dealt with that problem, and it was easy, is not the same context in which you and I operate here. So it was easy for me to make the link with the pharmacist somewhere in Yorkshire and say, take over. But here, what do you do? So that's the lingering ethical dilemma that I will leave hanging for you and I to go and think about as we carry on with our daily lives. Thank you very much.
Dr. Shitabe, I will want to chip in this before you run.
Yes, sir.
Because it's so important. you come in with all these good intention, what you've been doing about very important. And this type of case, we should be able to highlight that in the setting of Nigeria, you see, the GP is really handicapped. He can't take this clear decision, which is a professional ethics setting to take. Because even if it does so, the patients can still go outside and buy all these drugs. So it comes to the point we've been making that to the Nigerian Medical Council, we've got to have prescription right in Nigeria. So, maybe when you're having your final point of this, let's say that, and let it be in the media. Nigeria is the only country in the West Coast that has no prescription right. Even in Togo, Togo's population is about that of Ajegunle, you cannot get ampicillin to buy. And we've cried this. My 4 years in medical council, we shouted, and the paper died in Abuja. So we have to do something about prescription.
That's right, absolutely right. Prescribing, it's all part of the ethics of the profession. We really must get prescribing right.